I'm Scott, and I'm from Cyberonics. We're the company that makes the vagal nerve stimulator, VNS. And as a company, we're really all about technology and how we can leverage technology in order to help improve the lives of patients who have epilepsy. This talk that we're going to do now is kind of going to be trying to cover a lot of information in a short amount of time. So we have 3 speakers that are going to come up and talk about 3 different new technologies. And what we'll do is, if you guys don't mind holding your questions till the end, we'll kind of try and leave the last 5 or 10 minutes to ask questions about any or all of those technologies. So the first person who's going to speak is Charles Anderson from HiPass, and they are the makers of the Sammy monitor. So welcome, Charles. And then we're also going to, and I'll have all of you guys come up at once just so that we can try and keep this moving. We also have Dr. Tom Lay, who's a pediatric epilepsy or pediatric neurologist here in Orange County who sees a lot of epilepsy patients. He's going to talk about the newest VNS device, which is the Aspire SR. So thanks for joining us, Dr. Lay. And then also we have Debbie Frischnick, who is a neurodiagnostic technician, and she is here from Lifeline's Neurodiagnostics. So how about a warm welcome for our 3 speakers. And I'm going to turn it over here to Charles to get us started with the Sammy monitor.
Thanks, Scott. I also want to thank Brad and Candy for organizing this and inviting me to talk. So, Sammy is a video-based nighttime monitor. And I'm sure everybody here knows or is having difficulty sleeping. If you're not having difficulty sleeping, you should be having difficulty sleeping, because nighttime seizures are important and they often go unobserved. Seizures happening during the day, usually somebody witnesses it, but seizures that happen at night are often unobserved, and they can be dangerous. So Sammy has 2 main purposes. The first one is to reduce stress on the parents. So like I said, you're probably not getting good night's sleep. The second purpose is to empower parents in helping get the proper treatment for their children. So I'll speak about how it addresses those 2 things. Regarding reducing stress, we have a child with epilepsy, and his seizures were primarily at night. And so we tried baby monitors. And the problem with baby monitors is that it actually makes it harder to get sleep because you hear every little thing coming through. And so this was driving my wife crazy. And I'm an engineer by training, so I figured there has to be a better way to deal with this. So Sammy is based on a infrared camera, and you mount the camera on a wall looking down at the bed, and there's one being passed around so you can see what it looks like. Like a baby monitor, it gives you a live video feed. It works over Wi-Fi and connects to an iPhone or an iPad or an iPod that you typically would have sitting on your nightstand and at the parent's side. Sammy watches for movement. So Sammy looks for any kind of movement. It doesn't have to be rhythmic. A lot of seizures are rhythmic, but a lot of them don't have a rhythmic component. So Sammy doesn't discriminate. What it does look for is movement that is continuous for a period of time that you define. So the movement typically rolling over in bed, even getting out of bed, only lasts a few seconds. But if the movement continues for 10 or 20 seconds continuously, that's usually an event that you want to know about. So normally Sammy's sitting there on your nightstand, just displaying a clock. And when these criteria are met, it switches immediately to a live view. And by the way, it works in complete darkness, so it's an infrared camera, so you don't have to have any light in the room. It switches to the live view and turns on the audio so you can hear what's going on. So you can very quickly, as a parent, assess whether or not you need to get up and do something or not. In our case, it was very accurate. If that alarm went off, we'd have many nights when it would not go off, but when it did go off, it would usually be something that we would need to address. So the second aspect is empowering you with getting good treatment. You're often asked, okay, how long did the seizure last? Can you describe? Did it start on the left side? Anyone that's attended a person that is seizing is not looking at their watch. They're not remembering it, and they always seem to go on for 10 minutes or longer. So Sammy makes recordings of all movement through the night, and you can very quickly go through and review all the movements that happen through the night. And if there's something that's important, you can take it and show it to your doctor. And you don't have to remember or describe, you can just show it to them. And you get very accurate timing of the duration. Sammy starts recording before movement starts, so you get that very first movement, which some doctors have told me is important in trying to localize the seizure origin. So it's a useful tool for both getting good night's sleep and for helping your doctors figure out what's going on. And also learning whether or not medication is actually working or not. You know, it may be that seizures are being reduced during the day, but they're not being reduced at night. So it's important to know and help your doctors by collecting data, and this is a tool that lets you do that.
So Charles, could you mind just
Yep.
moving on so that we can get through everybody?
I think I pretty much covered it. We're shipping it. You can buy it from the website. So far the feedback that we've been getting has been excellent. Thanks.
Thank you all for sticking around so long. I know we were originally scheduled to be here earlier, but Dr. Sankar, who's always running late, pushes all back, but he's always good to hear. I'm a private practitioner, and I train at Children LA, so Dr. Holder actually came after because everybody I train under sort of scattered to the wind, Chicago, Toronto, and everywhere else. And I'm more of an IT person. I mean, I grew up in a family with hackers, basically. So I'm actually the IT support person as well as the practitioner in the office. So I maintain all the Ethernet, wireless, server, and everything else. So technology is always kind of cool. So this kind of Sammy and everything else is very nice. And we're one of the first group to implant VNS in children in 1998 in Long Beach, by the way. And CNN and Channel 7, I believe, were there for the first implant of my patient as well as my partner patient. And so the exciting news is actually been waiting for a very long time since the VNS was approved in the late 1990s, is actually there's now a detection module for seizure. And that's what I was asked to describe today is actually the VNS model 6. So what it does is that it still zaps your vagus nerve and sends signal to your brain and then stop the seizures. And this has been known since back in the 1880s, by the way. And of course, back then, they actually used carotid compression with some kind of electrical generating device that's not exactly what we have, very crude. But what they saw was that the seizure interrupted. Of course, people pass out when you compress the carotid artery long enough, and they can die if you do it too long, obviously. So it went into a little bit of a hiatus. Back in the 30s and 40s, however, they start getting more interest. Of course, we got more electrical stuff, and then when the electronic comes into being in the 60s and 70s, and then in the 80s, there's several institutions that then did the experiment, did a clinical trial, and got it finally approved. But the one thing we always wonder, in addition to the magnet swiping that can block the seizure, well, what happened when you don't catch it? And so now with the electronics being so good, and I think they borrow a lot from the cardiology people with a pacemaker, and that's why a lot of technology can cross over. So in fact, I think cybernetics are merging with a cardiac pacemaker company, right? Yeah, exactly. Yeah, so their technology, there's a lot of cross-fertilization. That's what I really like, and these are very cool kind of thing. So the new chip actually would detect the seizure, and how it does that is that we always know that when you have a seizure, 80% of the time or so, your heart rate spike, right? And so it's varying a little bit from people to people, and sometimes they don't. But if you put the chip in there, like the Apple Watch or the Fitbit or anything else, and then it tells the chip, hey, this may be a seizure, and if you program it to go ahead and send an electrical signal, you don't need a magnet anymore. Okay? And so since April or so, it's been approved, and I have close to 300 patients with VNS, by the way. And so I've upgraded about 10 of them and added about 4 or 5 more. And the one interesting patient is that he has seizure usually at night, and we can't catch him. On each telemetry occasion, we'll catch him, but not always. And the one thing about the seizure is that when you have too many of them, they decline in learning and memory. And I think Dr. Holder mentioned about the medication for seizure, including CBD, that can cause damage and actually learning problems. So in fact, phenobarbital, which has been out since 1912, is known to cause permanent IQ loss. And so is Depakote. And any number of seizure medicine we have on there, there's some evidence with long-term usage can cause permanent loss of IQ and learning. Okay, so we don't have the data on CBD, so I'm a little hesitant about prescribing something that can cause your children not to be as smart as they could be. The interesting about the VNS is actually it simply does the opposite, by the way. So this one particular kid, when we implant him with the Model 106, he started to actually have better performance in school. And the one thing about the nice thing about the chip is that you can go back and look to see how many times it's been activated after you program it in. So it sort of give you a surrogate, hey, there may be seizure you're not catching at all. And the first time you come back after a month, there's about 14 activation per day of the auto stimulation. Okay. So we went up a little bit, he's better, and then it got worse again when it came back, oh, now it's going up to about 30 times a day. So we adjusted a little higher. The last feedback I had, hey, he's back to himself again. He's learning. He's not looking like he's wandering around drunk or something like that. And he's doing a lot better. There doesn't seem to be as many seizures around. And clinically, it looks like he's doing better as well. So this is one of the few things that as we get more upgrade across everything, your smartphone, everything else, they start putting in a chip and makes them a lot better. Okay, so again, I'm a science fiction fan, by the way. And so somewhere down the road, we're going to have chips for everything. Okay, I mean, I have a patient who has Parkinson's disease who had the DBS implant. In fact, I just programmed the person for the other side just last week because his tremors start getting worse. The cool thing, within 5 minutes of changing the programming, no more tremor. None. His walking's improved, he's having left balance problem, and he's not on any medication for the Parkinson. Okay, so again, these are all very nice technological advances, and I expect to see a lot more before I retire. Okay. Again, I just want to give a little snippet, so I'd like to give you sort of an idea in terms of technology is something that can be very helpful. Of course, if you use it incorrectly, it can be overkill as well, so you have to be very careful, obviously. But I think that in addition to medication, there are other things we can do that is really different and actually can be really a different approach that can help our patients. That's why you're all here. So I applaud you for coming in to help your family members and everything else. Okay, so if you have further questions, please wait at the end. Thank you.
I have to have my memory here because I don't have a chip in my brain. So how's everybody today? Good. My name's Debbie Frischknecht, and as they said, I'm a technologist and I'm a registered tech. I've been registered since 1990. I've got 4 different modalities in neurodiagnostics, and I've managed a neurophysiology department for Children's at Eggleston and the EMU. So what I'm going to be talking about today is bringing your long-term epilepsy monitoring with video to your home. As you know, a lot of times if you're trying to get scheduled into an EMU, they may have long wait times, etc. And Lifeline's neurodiagnostic systems, who I work for now, we have several devices that you can now bring into the home. The tech can actually come in your home, set you up, have cameras that are monitoring you, and that data can be live streamed up to our cloud, and then your physician can log in to the cloud, and they can actually go through and be looking at the data. Live. We've got some that can do it live, etc. Right now, we're using a number of our systems with different pharma trials. I know last week, for instance, we had a study in Singapore, and the doctor was in Illinois monitoring it. So it's pretty decent stuff. So I'm sure most of you, I talk really fast, so I'm not going to get my 10 minutes, am I? That's okay. So oftentimes, there are times when you definitely want to have your long-term studies, video ambulatory studies done in the hospital. If there's medicine that has to be administered by the nursing staff, but oftentimes the hospitals can be inconvenient. They can be expensive. Often you have families that can't take the time off to get to the hospital. That's when the home-based monitoring really does make sense. The sites that we have currently out there, we've got one company that has over 80 different techs that go out and actually put the studies in different homes. And then they have a whole bank of monitoring techs that are there monitoring the studies as they're going. If they see something, then they call the physicians in on it. Okay, and they do have cameras. We're really, really excited. We have a product that hasn't been released yet, but it's going to be coming out in the near future, where we have actually wireless cameras that can go home with the patient. So you could have a camera in different rooms while they're still being monitored with the EEG. And this little device, how many of you had EEGs? A bunch. So you know the little amplifier that they plug all the electrodes in, kind of big and bulky? This is an amplifier. Now this one is not for the long term when you go home. This whole little guy here is made for the ER. So if you're rushed into the ER and you're in status, or they think you're having a seizure, they can easily just throw this on. They got this little itty bitty monitor, and all they have to do is push a button and it'll start the study. And it's meant more for people that are not registered techs to use. So the nursing staff would be able to capture that seizure right away and see exactly what's happening with you and actually report that data back to the doctor.
What I want to do now is open it up to questions. So if you have questions for these folks, just let us know who your question's for, and I'll get them in the microphone. So,
The gentleman in the blue jacket.
Charles.
Yes.
Can you monitor, it's like my teenager here, with a bunch of blankets? We live in Utah, it gets pretty cold, so you got to throw on a lot of blankets.
Right.
Will it sense that motion through the blankets and that in her bed and that? Or?
So it's very sensitive. It takes very little motion to start for it to detect that there is motion going on. I have not seen a case where the only time we have trouble is if it's just facial movements. But if it involves body parts under a blanket, usually the blanket will move to some extent, and it doesn't have to move very much.
Thank you.
So right here in front. Yes.
Is it Dr. Tran?
Lay.
Dr. Lay?
Yes.
Okay, what is your first name?
Tom.
Tom Tran.
Yes.
Tom Lay.
Yes.
Sorry. You mentioned Depakote, long-term use of Depakote.
Depakote, valproic acid. That's right. Divalproic sodium is the
Impact the IQ.
It can impact the learning, not only for the patient, but if the patient is female and pregnant, it impact the fetus IQ and learning as well, permanently.
And what is considered long-term?
Lifetime.
Oh, I see.
I'm sorry. In terms of usage total, phenobarbital, a couple years, Depakote, at least a couple years, and you see actually permanent
To start seeing.
decrease in learning and IQ. Testable on neuropsychological IQ testing, you can see the decline.
Thank you.
Yes, right here.
Hi, I have a question about VNS and medication. Is there a percentage, or what's the percentage of a reduction in medication once the child is on VNS?
Again, it's variable depending on the epilepsy type. I mean, I can only tell you my experience, which is of course several hundred patients, but most of them, at least one seizure medicine can be reduced or eliminated, and it's a lot of times two. So if you're only on two, I have a handful who's not on any medication. Most of them end up still with at least one medication, but the side effects of medication, which I did not mention, can be suppressed and be lessened by the VNS itself. So that's very nice for the patient. They feel better. they have less side effects on from the medication by the VNS suppressant. That's been my experience.
Yeah, right here in the middle. Go ahead.
Hey, Dr. Lee again. I was on Depakote for 6 months. Was that still lower my IQ or?
Doesn't seem to be so far. It looks fine, right? Yeah, I think you're okay. And we're talking at least a couple years, typically, yes.
The problem was when he transferred from, I don't know if it makes any sense, but he was given the brand before and then he was transferred to the generic one.
Yeah, the chemical is very much the same.
That's
Yeah,
what
it's just
told us.
the release in the body is
Yeah.
different.
But it was when he started having the contraindications. That's why he's worried.
Yes, he should be okay. I think he looks okay. Yeah, he's fine.
So here in the back, go ahead.
Alright, so the Depakote seems to be a big thing, but I'm just I've been on it several years, and where can I find the statistics, I guess, and do my own research?
And again, Google is the big, 800-pound gorilla. You can search medical articles about, just put in about boric acid and learning difficulties. Not everybody has the same degree, and not everybody is completely affected. Some are not. Okay, but in general, again, if you're a child developing, you are much more effective than if you're an adult, because your brain is more mature and you're less vulnerable. When you're a child, you're much more vulnerable to everything. Tobacco, marijuana smelling, alcohol, any drug you put in, you're particularly susceptible. If you have epilepsy, you already are susceptible, so we don't want to push it to the part where you actually get even less learning ability and so forth. But I think you should be fine if you were started when you were much older. Does that make sense?
So, ma'am, right here in the purple.
Yeah, have they, the new VNS, how do you get the new part put in?
Oh, again, whenever the battery become not so great on the old one, then we drop one complete, because the battery's sealed in, just like your iPad and iPhone.
Yeah.
And then you get the new upgraded chips and everything else, and the new model is what has the new refinement with the chip with seizure detection.
If it has a couple of years to go, is there a way to kind of get the new battery put in before that?
Good question, yes. I have one that has come up the same thing, because he is now only seizing at night, but mom's don't want to stay up through the night to activate the magnet. So we are making a case for earlier upgrade to control the seizure. Again, we want complete or as much seizure control as possible, particularly that night when you're at risk for SUDEP. I think everybody here have an understand what SUDEP is. That worries me at night on my patient. So yes, we are upgrading his from a 103 to a 106 earlier. Okay, for that refinement enhancement, correct.
So, did you have a question?
Yeah, I just want to know, are there any learning disability for the Kepra? If you take the Kepra?
Long-term wise, there doesn't seem to be any, as far as we can tell. And it's been at least 20 years since I've been out and there's enough study. So I think we're pretty comfortable that's one of the few that probably does not cause problem. Of course, it does have the hyperactivity and sometimes rarely psychosis in children, and they can make those more teenager-like, so sometimes that's not such a good idea, obviously. So we usually switch them when we see behavioral difficulties, but usually it's not permanent as far as we can tell based on the data we have. Does that answer it?
Yeah, but my son's in the university already. But my question is, when can he stop if he does not have seizure for maybe a year or 5 years?
Usually the data for adults is that you want to be at least 10 years or so. And again, you want to have the brain forget about seizing. After a while, it doesn't do things very well when it hasn't done it for a long time. In children, it's a little bit different because the brain is maturing. So our data is that 2-3 years seizure-free, and the EEG becomes normalized. There's a good chance, 2 out of 3, that you won't come back even off medicine. Adults are a little bit difficult because if he has a driver license, one seizure and he loses it. And so you then become the mommy bus or taxi, and you have to use Uber or Lyft or the bus. And this is California, so it's very difficult. Utah has been a right route, and I like Utes, by the way. There's Utah School in 1992. And so that's a little bit different, but here public transport is hit and miss. So my adult patient, and I still have a few, they really don't want to come off and say, I'm doing fine my medicine, I take it, it's my sort of safety blanket, I don't lose my driver license or my job because I've had a seizure, everything can change. So even when their risk is smaller, it's not zero. It's kind of come down to like 10% or less when they're 10 years or more seizure free. They don't want to take that chance. We don't take them off, they don't want to come off.
Thank you.
Especially on a drug that doesn't have side effects for them.
What's the youngest you can implant someone with VNS?
The youngest patient I had implant was 7 months old. He's about 9 now, doing really well.
We got time for one last question. Anybody?
I did want to know, how can you get the EEG at home? What are the steps that you need to take to?
First, you have to find a provider, somebody who's using the equipment and that can provide it. If you come to me later, I'll give you my card and I can tell you some of our customers and I can put you in touch with somebody in your area.
Great, thank you.
Then the doctor prescribes it, they come out to your home, they get your EEG done.
Great, thank you very much.
You're welcome.
Awesome. So how about a big round of applause for our 3 panelists up here, Charles, Dr. Ray, and Debbie.
So our next speakers, as you can see, are 2 sharp young men, new to the Southern California demographic. This talk is called New Faces of Pediatric Epilepsy Surgery, and I would love to introduce 2 new pediatric epilepsy surgeons in Southern California. We have Dr. Arya Falla from UCLA and Dr. David Donna from Rady's Children's Hospital. Thank you, sir.
Hi, everyone. It's my pleasure to be here. Thank you, Brad, for inviting me, and I think this is a fantastic venue for epilepsy, raising awareness, and a great opportunity to interact and learn more about disease process and what we can do to treat it. So I'll give you a little background. So I did my residency at the University of Toronto in St. Kitts Hospital. As very prominent epilepsy center. Actually spent some time at the Cleveland Clinic as well throughout my residency, which is also another major center. And then my fellowship was in Miami Children's Hospital, again another major epilepsy center. And now I'm at UCLA, which again has a long tradition of epilepsy. Each one of these institutions, they work up children differently, and there's value to have gone to different institutions and seeing how things are done differently, and ultimately being able to provide all the tools that you can to best treat each child differently. Each child and each epilepsy syndrome is different, and they all need to be looked at individually. So it's nice to have all the tools. The tools don't give you the answer, like you need to know how to use the tools that you have. But it's great to be able to use all of them. So how I became interested in epilepsy, I'll tell you briefly. I actually don't have a family member who's affected by epilepsy, but it's through my training that I met a 5-month-old boy with tuberous sclerosis complex, which is a rare genetic disorder, and that often leads to epilepsy that doesn't respond to medications. And for this child, we're able to work him up, and we're able to offer surgery, which was frontal lobectomy, so removing the frontal portion of the brain, which is a large operation. And this child was seizure-free, which was great, except for I think we can do better. I think we can do better. And as epilepsy surgery, I think, is a fantastic option when it's available, and it can be very successful. But at the same time, hope we get to the day where we can do things less invasively or preferably non-invasively to treat epilepsy. So we have a long way to go. But that was my first sort of, that child, that baby was the person that kind of triggered my interest in epilepsy and why I wanted to go into this field and do better for children like him. I think it's very important to be at a center especially for children with epilepsy, to be at a center that specializes in children. There's a lot of nuances to treating epilepsy in children. And one of the most important things is the pediatric neurology team with the experience that they have, because there's many types of epilepsy where surgery is not the answer. In fact, we can't help with surgery. But they need to be thoroughly evaluated by a very experienced team. But when surgery does become an option, often we can achieve good results. And our goal with epilepsy surgery in children is severalfold. One, most importantly, to stop the seizures. We don't, as a result of our surgery, we don't want to inflict any deficit. So we don't want to, oftentimes this involves removing a part of the brain. But as you know, different parts of the brain have different functions. And obviously we want to do this as safely as possible. With kids, especially when they're very, very young, we have the luxury that their brain is plastic, what we call plastic, meaning the brain can take on new functions. So just because, you or I, at my age, if you remove a part of my brain, that will be a permanent deficit. In very, very young children, their brain has the ability to regain function. So that's something that we try to take advantage of. But our goal is to stop the seizures, not cause any deficits, and most importantly for the growing brain, anti-seizure medications are great at stopping seizures sometimes, but also they have a lot of side effects. And everyone who has had children or family members with epilepsy know that these medications themselves can be toxic. One of the goals, especially with kids as their brain is developing, is to try to reduce the number of seizure medications they can be on. So ultimately, I think we're in the era that we can offer a lot through surgery, but I still believe there's a long way to go as we try to evolve with our techniques, our ability. There's still no perfect way. There's no perfect way for us to visualize a seizure and know for sure exactly where it's coming from. We get clues by, we have a lot of fancy imaging tests, by meeting with the neurologist and describing how your seizure is, and by watching your seizures, we get clues as to where the seizure may be coming from. We still don't have technology to visualize seizures. So there's a lot of work that needs to be done. Ultimately, one of the bigger questions, something that I'm personally interested from also not only in treating patients with seizures, but from a research standpoint, is being able to predict how you will do with surgery, which is one of the most important questions as we talk about epilepsy surgery, being able to predict an outcome. We don't have a crystal ball yet, and we want to be able to tell with very, very high certainty not what the population, how the population responds to this operation, but how your child will respond to this operation. That's something I'm personally interested in, and I think venues like this would be great to raise awareness, but also we have a lot of work that needs to be done in going forward. Thank you very much. I'll pass on the mic to David.
Thank you very much. I'm glad to be out here. Appreciate Brad Levy for inviting Rady Children's Hospital and myself to come to this event. I feel very connected to the people here. This is my home. I was born at a hospital less than 5 miles from here. And I too have a child who has epilepsy. I can share some of those fears of not knowing when your child might have his next seizure, or what the effects of those medications they're taking are. on their developing brain, how they're whether it's slowing them down, whether they're losing IQ points, whether they can be better than they are being. I remember when my son first started taking medications, they affected his balance so much I was having to hold his hands walking up hills that my other children were running around and playing just fine on. So epilepsy means a lot to me, and it's something that I want to help make better in our community. And I'm glad to be down here in San Diego at UCSD and at Rady Children's Hospital to be able to work on that. My history, I went to The Ohio State University for medical school. If there are any Buckeye fans out there, flying out there for a game this weekend. And from there I came to San Diego where I did my residency at UCSD. One of the things I noticed in residency, because that's my son during my residency was when he developed epilepsy, and I started attending with my family and my wife and kids the local epilepsy foundation support groups, try to find out how we can find better treatments and things like that. And I kind of stood out at those groups though because I was a neurosurgeon, and it became obvious. People would start pointing and they come up and talk to me about their kids, and I realized when families would come and they'd say, my daughter has seizures, and one thing we've noticed is every time we tickle her, it'll break her seizure and we can stop her from having a seizure. And then other people will come up to me and tell me about the seizures where they have mesial temporal sclerosis and things like that, and none of these children had been evaluated for surgery. And some of these kids had signs that they would respond very well, whether from a VNS or whether from some kind of an operation, but they hadn't even been evaluated. And I think that happens way too often in our community. Not enough children are getting the full evaluations to determine whether or not they have a curable form of epilepsy, or whether or not there's something that can be done procedurally that will decrease the incidence of their seizures and maybe decrease the amount of medications that they have to take to control those, decrease all the side effects of the medications that they're having to take to be able to control those medications, or to control those seizures. And during my residency in San Diego, which is a phenomenal program and a great place to train, but I looked around and I realized, we're not doing a lot of epilepsy surgery in San Diego either. Either on the adult side or the pediatric side. The occasional tempelobectomy, but not very much else. So when I went away from my fellowship to become a pediatric neurosurgeon, I went to Texas Children's Hospital in Houston. It's an enormous medical center. They have a very large referral base, one of the largest patient volumes in North America, I think, for a children's hospital. And I went there because there was a guy named Dan Curry who's doing a lot of epilepsy surgery, and I wanted to learn epilepsy surgery because that was something I wanted to bring back to San Diego, and that's something that I focused on the entire year working with him. And I had some of the best training I think I could have gone anywhere in the world working with him. One of the things that I learned from Dan Curry was some of the new technologies that are available out there, things like stereotactic EEGs, instead of having to do a formal craniotomy to replace the grids on the brain, less invasive ways to treat seizures. I learned how to treat patients with hypothalamic hamartomas. If anybody knows what a hypothalamus is, that is the very center of your brain, one of the most delicate portions of your brain. And people have a hamartoma there, which is a benign tumor. It doesn't grow, but it causes seizures. The traditional surgical approaches for those carried a lot of morbidity because as you try to pull it off the hypothalamus, there were a lot of side effects from that. Kids would come out and require hormonal medications for the rest of their lives. They would have to take hormonal medications just to be able to control how much urine they're making every day. Some of them would come out and would have hyperphagia. They just could never get full, always wanting to eat, or they may not have hunger at all. And we learned how to treat these using the laser technology by putting a fiber optic cable in there and burning them and disconnecting these tumors. And I saw over a dozen children treated with this who went home the very next day after surgery and were cured of their seizures. Overall, I think their seizure control rate was about 80 to 90%. curate on that. So working in this program, I could see less invasive ways, some of the newer technologies of treating these terrible epilepsy syndromes. And I'm proud to be able to bring that back to San Diego, to bring that home, and be able to share that with the community. Rady Children's, we've just acquired the ROSA, the robot, for doing stereotactic EEG. It's a stereotaxy machine that helps us place depth electrodes or catheters or biopsies or whatever we need in the most minimally invasive way possible, and in the most exact manner that we can, and to do it very efficiently in the case of stereotactic EEG, where placing 12 leads traditionally could take 8 hours. We can do it in about an hour and a half. And then, of course, there's the visual laser, the neuroblade lasers themselves that we're able to use for some people, depending on what their epilepsy syndrome is, and be able to treat it with again, just a burr hole rather than a total craniotomy. It also opens up the number of people who are eligible for surgery. A lot of people who have been turned away saying, you know, you have 3 or 4 lesions, we can't do a craniotomy and take out all those, so you're not a surgical candidate. So most people are surgical candidates when you can treat them in a less invasive way, something that's repeatable, something that they can go home the next day and come back. If it doesn't work, we can go for the next one. So there are a lot of big strides forward being made in this field. And at the UC program, not just UCSD, but UCLA and UC Irvine. I think we had some other speakers from them. So it's a great system to be part of. There's a phenomenal research effort that's going on with the university. We're doing some brain mapping studies with the electrodes that we're placing in the children. Kids who have to have these electrodes placed in the brain to identify the seizure focuses. Anyways, they're sitting in a hospital bed for a week just waiting to have a seizure. We have some of our engineers on campus who are coming and giving them an iPad and telling them to watch movies. And the iPad watches their eyes, and it sees what they're, and it records what's happening in their brain, where the waves from the brain are based on what they're looking at, what they're thinking about, where their eyes are moving. So we can begin to map better the function of the brain to be able to treat them in the future. So we have exciting research like that going on. And we have great scientists who are doing genetic researches, genetics on the tissues that we take out of what's causing the seizures. What are the genes that are mutating, the chemicals that are unbalanced inside the brain that's causing these patients to have. And as we gain a better understanding of that, we can find medications and other ways that are less invasive than surgery to be able to treat them. So these are exciting times to be involved in epilepsy and to be part of epilepsy and its management. So I have anything more to say, but thank you guys very much for coming.
Any questions? Yeah.
How many hemispherectomies have you guys actually performed as the lead surgeon?
As a lead surgeon. So I personally, hemispherectomies are the biggest volume places. Probably do about 10 a year. As the lead surgeon, probably 7 or 8 for me. I actually flew down to Chile as a guest professor to help them with their first 2 hemispherectomies on a 6-week-old. 6-week-old and a 6-month-old as well. So.
I've not done one yet. I just finished fellowship a few months ago, so I've done hemispherectomies. I was trained in how to do them. I've done them as a fellow and as a senior resident, but on my own, we have a couple coming up in the next couple months. But as of right now, in my first few months, I'll have to.